Hello everyone and welcome to AceOSCE's video for today. This is Alicia and thanks for joining me. This is going to be my last video of my pharmacokinetic series of videos. This is going to be going ahead and having a quick overview of elimination, reminding you that this is only a quick overview to discuss the most important topics in this specific chapter. And there is a lot more comprehensive knowledge that you need in order to pass the exams to make sure you're all prepared for it. Try to attempt to answer the question at the end of the video. So let's have a quick look at an overview of elimination. In case you guys have any questions or concerns, definitely reach out to me. I hope this helps you guys in any what little way it may. Elimination is usually the process of removing the drug from the body or elimination or excretion. It is primarily cleared by the liver or kidneys. Urine is the major source that excretes most metabolites and unchanged drugs. Most drugs are eliminated by first order process. I will be going through what zero order and first order kinetics are in terms of elimination in the next slide. But in first order processes, the amount of drug eliminated is directly proportional to the serum drug concentration. Therefore, the amount of drug given in a dosing interval equals the amount of drug excreted at one point in time. Once this is established, it is referred to as the steady state concentration of that medication. This is an important concept. You need to know what a steady state of a drug's dosing or a drug's concentration is. This is a very simplified way to explain what it exactly is. So do definitely read a little bit more about it. Again, any questions, feel free to reach out to me. Now I'm going to show you a slide comparing first and zero order kinetics. In terms of first order, the plasma drug concentration influences the rate of the drug metabolism. Also, this drug metabolic rate is not a constant in first order reactions. However, in zero order reactions, pharmacy drug concentration does not influence the rate of metabolism, and the rate of metabolism itself is constant. One more major difference is that in first order kinetics, T-half or half-life, which I discussed in my previous metabolism video, is a constant, whereas in zero order kinetics, T-half is not a constant. I've tried to illustrate the difference between the two order kinetics by showing a graph between concentration and time. If you see the solid line, that represents first order, and the dotted line represents the zero order, which is a straight line. In terms of zero order, for example, 1 mg of the medication is eliminated per minute. However, in the first order, it's 1% of the drug that is eliminated per minute. So I just wanted to give you guys a quick example as to what the difference between the two is. You may just not understand it with these slides alone, but definitely you want to learn a little bit more about this in case you don't know what these are already, or some common examples of medications as well. One thing to also keep in mind is that in first order kinetics, the T-half is constant. Therefore, for calculation purposes, first order reactions have the same T-half, so easy calculations for formulas. Another important concept in this chapter is clearance, or as I have denoted here, CL, which stands for clearance. It evaluates the efficiency of drug removal from the body. It is not an indicator of how much drug is being removed itself. It only represents the theoretical volume of blood being cleared of the drug per unit time. So nothing to do with the drug per se, it is the volume of blood that is being cleared off per unit time. Make sure you do not confuse it with creatinine clearance, which I'll be covering later on in this video. It is usually a first order process, and the amount of the drug removed depends on the drug concentration, as we discussed with the first order processes. Clearance can be denoted by dose rate, which is again not the dose of the drug, but the dosing rate. So depending on the frequency of how often we're administering the oral or IV or SL medication, whatever has been asked in the question, divided by the average steady state drug concentration, again steady state. Elimination rate constant is yet another important concept that you guys should know. It describes the fraction of drug that is eliminated per unit time from the body, or the rate of plasma drug concentration decline during the phase of elimination. I also wanted to show you guys the difference between the log concentration versus time graph and just the regular concentration versus time graph. When you see the regular drug concentration versus time graph on the left, you'll see that there's a slope. You'll see there's a curve, it's not a slope. However, when the log is plotted for the concentration against the time on the x-axis, you'll see it's actually a very clear slope in most cases, especially when we see first order reactions. And this slope helps us to calculate KEL, or the elimination rate constant. Another quick look at important formulae from this chapter. Now we come to creatinine clearance, which is different from regular clearance. It is the volume of plasma cleared of creatinine per unit time. So not specific to a drug that is being cleared. It usually compares the creatinine per se, and therefore it's a function of your body. It measures kidney function. Therefore, it usually is affected or is decreased by renal filtration, secretion, or reabsorption decline. These are the three processes that the kidneys, nephrons usually use to clear off medications. So if either of these processes is compromised or the number of nephrons decrease due to age, due to other medications, the creatinine clearance will be impacted. Normal values for males and females are listed here in ml per minute. And this is also affected by either emaciation, by age, like I said, advanced age, or unstable renal function due to medications or health conditions. If you plot the KEL or the elimination rate constant versus CRCL, it is an upward slope. So important to remember this graph. Another thing to remember is how to calculate creatinine clearance. This is a common question for your MCQ as well as for your EEs. Again, I just wanted to reinstate that the questions that I usually share in the group are pretty straightforward, and that's because I don't want to take the time to actually write down all the questions that I discuss. I'd rather just revise the concept itself. That's my main aim. So this question can come in 1,000 different ways, so just keep in mind that you should know the formula. You only have to substitute the values. So CRCL for male, which is creatinine clearance, is 140 minus age into weight divided by serum creatinine into 72. One very important thing is therapeutic drug monitoring. This is an important topic in this chapter. It is the amalgamation of clinical lab studies that are done to measure a drug's chemical parameters that help or influence the drug's prescribing procedures. Medications that have a low therapeutic index means that they have high therapeutic changes in the body with just low changes in drug concentration that are administered. Therefore, they have a high toxicity, high chances of death if it is toxicity, and also high chances of having an excessive amount of the drug in the body, and therefore not enough or not good therapeutic effects. So medications such as digoxin, phenytoin, and lithium, they usually have narrow therapeutic ranges, which means an increased therapeutic response to small changes in the drug concentration. They may have unpredictable dose or response relations. They may have significant toxicity consequences, which most of us have seen. And they have readily available assays, already available assays or test results. So it's easy for us to therapeutically monitor these drugs, especially when we're giving them IV or giving them at certain intervals. So this is really, really important. I will be going through when and how to be doing TDM just in a very brief way in the next slide. So usually the tests for therapeutic drug monitoring are done at the steady state of the medication. This is done to avoid fluctuations or incorrect readings of the elimination rate and the drug concentration. Remember that the steady state of a medication is usually reached in 4 to 5 half-lives of the medication itself. And if we have a quick look at the concentration time graph of a specific medication, you'll see that it is a curve going upwards. And each time that we give the medication, every 6 hours, every 4 hours, there's a little peak, and then the medication's concentration starts going down. And then we give the dose again. So the times of dose intervals or administration are the little slopes downwards. And then the crests are up there, which help to kind of show that the medication is going up in concentration again. However, in some time, you'll see that this crest and trough come out to be very stable after 4 or 5 half-lives, which is referred to as the steady state plasma concentration of the drug. We have covered this video with just discussing the most important topics here. Today's question is a little tough, but I really appreciate and really want you guys to try to get the answer to this. During the therapeutic drug monitoring of drug A, a dose of 100 micrograms was reduced to 50 micrograms in 6 hours. When a single infusion of 2 liters of drug A was administered from a stock solution of 15 microgram per 5 ml, what would be the drug concentration in plasma after 2 days, assuming it's a first-order medication? The options are listed here. It may be a little convoluted. I just wanted to maybe pull through the numbers, push through a little, maybe just make it a little more convoluted for you guys. If PEBC decides to ask a very weird question to you, it may be looking a little bit like this. It seems to be really confusing, but if you know your concepts well and you know where to substitute what value, you'll definitely get the right answer. Do keep in mind the units. Okay guys, so we've reached the end of the video. I hope this helps you guys to understand a few concepts, especially in the topic of elimination. Definitely reach out to me on the platforms listed below in case you have any questions or concerns about your PEBC journey, about your PEBC exams, or even about this video. And I'll see what you answer in the comment section below. Take care.